what excites me about the opportunity to discuss this is the way the move of the conference has been in the direction of the clinical and the recognition of some of what we're up against. And I want to say a couple of things about each of the two previous presentations and then move us in a direction. What Joel does, importantly, is focus us on the reality that there's too many people for us to be able to be useful to. He recognizes the limited access to evidence-based therapies and the cost issues that are concerned. His approach triages patients to short, intermittent rather than intermediate, and long-term treatment in an additive model. This conserves resources, it minimizes waiting lists, it deals with real-world problems that we have to deal with as clinicians treating patients. Extraordinarily important. We cannot do 3-year treatments with everyone. We can't even do DBT with everyone who's in need. Now, Ken's meta-analysis is, of course, masterful, and I want to focus us a bit on the bottom line, since I'm certainly not someone who could argue the nuances of the statistical set. But basically, he's telling us, look, there are no meaningful differences between specific therapies for BPD, regardless of the orientation. If we're honest, if we look at it, they work. We may have our zealous favorites. By the way, I'm delighted as a Yankee fan to be here in Boston with the Boston people today. And for today, I'm a Red Sox fan. You know, when we have our fans, those loyalties matter, and they matter in our field. We might as well acknowledge it. And that publication biases are inflating our efficacy in ways that must cause us to think twice. I may have seen an earlier version of Ken's slide set, because in the one I saw, he also began to notice the impact of comorbidity, that this was a significant issue in the meta-analysis and in thinking about who are these patients, how are we going to find a way to address the real-world problems that we're up against if we have effective treatments. So where are we? Therapies work for borderline personality disorder, but the reality is that few clinicians will learn even a single evidence-based therapy for BPD. Nevertheless, most clinicians will be treating patients with BPD. That puts us between a rock and a hard place. And the question that emerges is, really it's one that Joel was alluding to in many ways. Are there common factors among effective treatments for BPD that could be taught and practiced, even by people who aren't proficient in DBT or TFP or whatever the hell else FP? And that takes me to the work of the Group for the Advancement of Psychiatry Psychotherapy Committee, the GAP-PC. The membership is here. You can see it includes a number of the people at the conference, a number of people whose names you may recognize even though they're not at the conference. And this GAP Psychotherapy Committee embarked on a project to try to think this through. It's an expert consensus panel. Now, having sat here today, I imagine that you may have some immediate and appropriate skepticism about an expert consensus panel and whether we can really trust that the same way we can a meta-analysis, if we can trust those, or a randomized trial, if we can trust those either. And so I like to include this slide when I talk about an expert consensus panel, because I think in our field we have a kind of self-esteem issue in which we think that the other fields are much better than the mental health fields about this issue. And so I just want to bring to your attention this study by Tricoci of the cardiovascular practice guidelines of the American College of Cardiology and the American Heart Association. The percentage of the 2,711 cardiology treatment recommendations supported by the highest level of statistical evidence, multiple randomized trials, systematic reviews, meta-analyses, is 11%. This is cardiology. 48% is based on expert consensus. So I just want us to hold that in mind as we think about the contributions of expert consensus panels. So here's what the GAP-PC did. It explored the convergence among psychotherapies for suicidal patients. Over a couple of years in our meetings, we argued back and forth about the similarities and differences between these 6 forms of treatment. It isn't every single one. It was the 6 we could gather experts on. It included DBT, CBT, schema therapy, MBT, TFP, and the way we approach suicidal borderline patients psychodynamically at Austin Riggs, which we call ABIS, because all God's children got to have acronyms, an alliance-based intervention for suicide. I won't explain it. It's very similar to TFP, although probably uses more emphasis on the alliance in the room as an issue in working with suicidal patients. We convened experts in these, and we said, okay, can we agree what the common factors are across all these treatments? Whether you're doing DBT or TFP or schema therapy, what are the common factors? And we found what we thought were 6, and here they are on this slide. We thought that across all 6 treatments, there was an effort to negotiate a treatment frame in a pre-treatment phase. The treatment didn't begin until there was a discussion about the responsibilities of each person in it and what the ground rules were going to be. You weren't just sort of stuck in a room together and treatment begins, but rather a clear negotiation of a pre-treatment phase, which incidentally includes what do you do if you can't manage? There's always a rescue plan. Number 2, to recognize and insist on patient responsibility. Regardless of what point of view our clinicians came from, we achieved agreement that we were really attending to the patient as an active agent. They had a job, they were responsible, there was something we expected them to do and needed them to do, even as they could rely on us. All 6 of the treatments used a conceptualization of the meaning of suicidal behavior and of associated treatment interventions. You gotta have a theory. You gotta have an internally consistent, coherent model of what's going on here, how do I understand it, when the countertransference storm gets intense and you're sitting with a suicidal borderline patient, what do you turn to help guide your interventions? 4th, all 6 of the therapies use the therapeutic relationship to engage suicide. 5th, suicide was prioritized as a topic in the sessions. With a suicidal borderline patient, nothing is more important than whether the patient is going to be alive for the next session. And finally, all of them seem to provide support for the therapist in one form or another, either direct supervision or consultation groups, or even manual adherence meetings. All of them tend to the needs of the therapist in ways that make it possible for the therapist to stick to the task. Now, when we examined the literature after our own expert consensus discussion, we found that there were several other groups that had done something like this. Elsa was part of the Boston Suicide Study Group, and they looked at candidate interventions. Paul Links looked at common principles in approaches to suicidal borderlines. Anthony Bateman wrote a wonderful editorial most of us are familiar with about a year ago in the American Journal. And John Gunderson has his principles of effective treatment. We looked at these and examined them, and basically we saw a great deal of agreement. I'm not going to take the time now to show you a boring chart of exactly where each one agrees and disagrees. I think that where some of the others made emphases that we did not were mostly around therapist activity. We thought that followed, that you had to be an active therapist to work this way. We didn't pull it out as an explicit detail, but we had no quarrel whatsoever with the notion that a therapist working with suicidal borderlines needed to be relatively active. And the other conundrum was this area of, do you address non-lethal self-destructive behavior in the same way that you do lethal behavior? And there were differences between our DBT colleagues and some of the rest of us about that. It wasn't something we could agree about. So where does that leave us? Well, so BPD seems like it's a treatable disorder. There may be common factors that allow us to address some of the kinds of public health questions that Joel was raising for us. We could more easily teach residents, for example, common factors than make sure they all are expert in a particular evidence-based treatment. But then there's the larger problem, which has been woven through our discussion today. You keep hearing the reference to comorbidity. It keeps turning up. And some clinical studies have suggested that as many as 40% of patients have personality disorders. And does that mean 40% of patients with major depressive disorder have personality disorders? I think that there's an issue that goes beyond personality disorders for us to think about. And that is that we who are interested in personality disorders may be the keepers of the understanding of why patients with other disorders, like major depressive disorder or bipolar disorder or lots of other Axis I conditions, don't get better. Let me take you into this a little bit. Most of us are familiar with the CLIPS study. And remember what Skotal and his group found, that personality disorders adversely affect major depressive disorder outcome, cause persistent functional impairment, extensive treatment utilization, and carry significant suicide risk. They say that personality disorders, especially BPD, robustly predicted persistence of major depressive disorder. Major depressive disorder is an even bigger problem than BPD, and they don't travel in separate vehicles. They travel in the same people. And he concludes, assessment of personality disorders is essential in patients with major depressive disorder. You all know the most common Axis II disorder made in America, deferred. It brings us to this issue of treatment resistance, and I noticed that John and Lois Choi Kane had a nice little piece at the McLean table that addresses some of this, that, you know, really we are, as a field, bumping into the reality of treatment resistance, and this is a real phenomenon. In a 20-year period in which overall citations in the field grew 25%, citations on treatment resistance increased 800%. We're starting to notice this. And there's no single definition that we've developed as a field across disorders. And in my field, psychiatry, all of the efforts to approach it are biological. Try this pill, then that one, then ECT. And it's not the same, I want to just make the point, it's not quite the same as resistance in psychoanalysis, which is about resistance to thoughts, affects, fantasies entering consciousness. In fact, the resistance isn't even probably located in the patients at all. It's probably located in us and in our biologically reductionistic stance toward treatment. I have Graydon's definition there, but we really don't have time to get into it. This is for major depressive disorders. And the evidence is overwhelming that people, for example, with major depressive disorder, which I'm using as an example, fail treatment at high rates, often don't recover fully, and are remarkably expensive, 19 times more expensive for the group who have treatment-resistant depression compared to other. Beyond treatment resistance itself, there's the recognition that comorbidity probably plays a huge role in this. In the large STAR-D study, when all was said and done, the people with comorbidity had much worse outcomes, and they were 80% of the sample. 78%, I'm rounding it to 80. 80% of the sample. So if you're a clinician and you think that your patients are sicker than the ones who were studied in the randomized trials, you're right. 4 times out of 5, they are. At Riggs, I think we work with these kinds of treatment-resistant patients, and Chris Perry already mentioned something about some of our statistics earlier, so I won't spend a lot of time on it, other than to say that this is the kind of patient we see with 6 different disorders, mood disorders, comorbid with borderline, comorbid with dysthymia, often with PTSD, and this is probably much more the kind of patients who we see in the world, even if they're not the kind who are put in randomized trials. And we feel like we've seen some pretty good outcomes with these people. Chris Perry was the lead author of the point made at the bottom of this slide that 75% of the patients who struggled with suicide as an issue at admission were free of suicide as an issue at 7-year follow-up. And this is not a remission issue, it's a recovery issue, same kind of mathematical modeling as is used in oncology. So what's the take-home message? Multiple therapies for BPD work, but there are very important access issues. Stepped care offers a useful triage approach. How do you think about managing the resources for a big problem like this? Third, few therapists will learn even one therapy for BPD, so defining common factors may be of significant value for training and for practice. And we should be thinking beyond BPD alone. Therapies for BPD may make treatment-resistant depression and other treatment-resistant disorders more treatment responsive. BPD is not simply a standalone diagnosis, though it is. It's an add-on that is of tremendous importance for us to recognize. So, I think I made it through in the time limit. Thanks very much.